Nate Kaufman, welcome. Excited to welcome you to the first Matterhorn podcast and kick it off with you. I know you're a principal and partner here at Matterhorn, but excited to spend some time with you. And really, as we kick this off, our goal really is to educate and inform, a lot of people in the healthcare industry, executives, talk about current topics, new developments, as well as, the context of over time, like what has been going on in the industry, whether it's hospitals, physicians, ambulatory services, ancillary services, all of those. And I know you brought some slides or some, presentation materials today, which I appreciate. But I guess we'll just kind of jump right into it. And before we do that, I guess kind of the place to start is let's start at the top. So what are the fundamental problems that are causing the healthcare crisis we see today?
So, as you said, I brought some visual aids. The fundamental problem in healthcare today is that government reimburses well below cost. There's some people that had this theory that Medicare is basically set to break even, but if you look at the charts we brought on the left side, what you see is that the not-for-profit hospital systems, this is the first time MedPAC has actually broken this out, the not-for-profits have a negative margin of about 15% from Medicare. And when you think about the fact that Medicare Advantage is 10 to 15% lower than Medicare, then the negative margin starts approaching 20%. So the only good news about that is that Medicare is a better payer than Medicaid. And so when you combine Medicare and Medicaid, the beneficiaries are the hospitals and providers are receiving reimbursement that's about 20% below cost. And the question is, then how do you survive? And just one other point about that. This is not to excuse health systems from not being exceptionally efficient. And many of them aren't, and many of them have many issues that need to be addressed and aren't being addressed. But the fact is, we have a problem with government reimbursement. And why is that? It's because if Medicare recognizes that they're under reimbursing for hospital care, they have to raise the payroll tax. So they'd rather make believe that it's not a problem. And the other problem in Medicare is how they reimburse physicians. If you look at the chart on the right, over 2 decades, Medicare has increased physician reimbursement on average by about 11% over those 2 decades. Meanwhile, if you look at the chart, that kind of lighter blue line, that's what it costs to run a physician practice. And that's increasing by 41%. So Medicare has rendered independent physician practice unfinancially sustainable or financially unsustainable. And so as a result, we've got huge problems in both. And just one other point about that is it's circular because the physicians can't support private practice. They then have to be employed by somebody. Usually it's a health system, and those health systems then have to raise their reimbursement somewhere to cover this new cost of physician practice.
And then the other thing that troubles me when I look at the second graph, the physician group and the perspective and the escalating, spiraling out of control costs, to be your own physician, to be your own standalone, put up your shingles, as you hear physicians say. Well, as we turn to the next slide and take a look at there, I mean, you talked about how Medicare, reimbursement and everything is hitting physicians and hospitals. There's only so much healthcare dollar. Who's getting all this? Like what's happening there?
Well, everybody likes to puke on hospitals, but when you look at the relative value, here is an organization that is open 24 hours a day, 7 days a week, and has to have the capabilities to treat anything that walks in their door. 40% of those hospitals right now are losing money, and many of them are unsustainable. At the same time, essentially the people that process claims, whether it's drug claims through their PBMs or insurance claims, they're making record profits. And one of the interesting things to note is how the profitability of the insurance companies, the for-profit insurance companies, have improved after the Affordable Care Act. I mean, the real winners, if you look at profitability, are the for-profits. They've gone from a $23 billion profit to a $76 billion profit. And their CEOs in 2022 of these insurance companies made a combined $136.5 million. So when I look at it, the people that are delivering care, saving lives are, I wouldn't say squeaking by, but they're definitely under financial distress. And the people that are processing their claims, they're making a fortune.
Yeah. No, I mean, we know that from speaking with clients. I mean, everything, they're all trying to grow volume and, in market share or access or however you want to put it, but then they always have to focus on their operating costs. They're constantly looking to tighten up. I guess when I look at this, I see this number here on a compounded annual growth rate is 10% growth. I mean, year over year, they're growing 10%. And you look at that. And so does this scream like, hey, hospitals, you need to be a Kaiser? Because you look at like a United, they're buying provider services, everything like that. Like, what are your other takeaways other than the people who aren't providing the care are making the money?
So the first thing is no, you definitely don't want to get into an adjacent strategy. Our data shows that what we call payviders or provider-sponsored health plans, if they are making money, it's likely because of transfer pricing. That is, they're their lowest payer for their hospital. But most of them are not making money. And so we caution against that. The real answer is there's plenty of money. There's $76 billion of premium dollar that could be redistributed to hospitals and physicians and others to provide care. So we don't have to raise premiums in order to subsidize the underfunding by the federal and state governments. But again, if you look at these large insurance companies, they're very strong in lobbying, and it's awful difficult for them to get regulatory pressure on them. One last point: when people ask me like, "What's driving healthcare in our country?" I call it greedonomics. I mean, you look at the drug companies, you look at the payers, you look at the device manufacturers, you negotiate with anesthesiologists, as I do, and what you find out that, I mean, economics is driving everything. Everybody wants to get what they feel they deserve, and there's just not enough money to do that.
I guess, the age-old question, you look at advisors, you've been around, you've got a gray hair or two. So
47 years.
Yeah. So with that, what concerns you about the advisory consulting industry right now?
Well, we at Matterhorn, we call ourselves Matterhorn Strategic Advisors, and our focus is on advice. There are many in our field that are more focused on a transaction and getting a percentage commission from that transaction. And there's really an easy way to tell whether you're being sold or not, and that's with the hockey stick graph. Whenever you see this, that is, we're here now in the valley of despair, but if you just listen to my advice, all kinds of wonderful things are going to happen.
Right.
We're going to apply these heroic assumptions. You're going to see every patient west of the Mississippi, and you're going to make tons of money. And the problem is that all of that's theory. And what I believe is if you can't create a profit and loss statement that doesn't have heroic assumptions to support a strategy, you shouldn't do it. And the other thing is that when you do see heroic assumptions, realize that you're not being advised, but you're being sold.
No, that's helpful there. I guess we'll turn to the next slide. And when you look at physician and healthcare providers, what are the issues they're facing today? Or what is the basic calculation? Or how do you approach any kind of strategic advice?
So people say that all healthcare is local, and it sort of is, but all healthcare has to solve the same equation. The equation is really simple. It's revenue minus expense equals survival, or if you're a physician group, revenue minus expense equals physician compensation. Now, the problem today is not a volume problem. In fact, the problem is too much volume. If you have a lot of Medicaid and Medicare underfunded patients pushing out capacity so you can't treat more commercially insured patients, you've got a volume problem. And you need less volume and more of the right volume. We see hyperinflation in expenses, especially among personnel, supply costs, and even debt now. And so we have to solve this equation, again, without using heroic assumptions. The challenge we have is, well, let's look at PE as an example. Doctors are told, look, we're going to come in, we're not going to, and we're going to reduce your expenses, we're going to increase your revenue, and as a result, your compensation, which we are going to reduce initially, called a scrape, is going to be repaired.
Right.
Well, it's turning out that, well, they may get more volume, but there's not a lot of PE firms out there able to negotiate better rates. And as a result, the revenue doesn't materialize. The expenses, they're pretty well fixed to a large extent. And then compensation doesn't get repaired. And so this is a great formula to use to present to any advisor and say, well, explain to me how your advice is going to result in us doing better in terms of survival and in terms of compensation. And if they can't do it without heroic assumptions, you have a problem.
So, I mean, what is like one of the number one rules or strategies going forward, in terms of being a healthcare provider?
This organization called the Center for Healthcare Quality and Payment Reform actually analyzed 600 or analyzed rural hospitals. So they found that 600 were at risk of closing, and the remainders were actually not at risk. And they went through and looked at the financials, and what they determined was that the only difference between a hospital at risk of closing and the rural hospital that isn't at risk is their private pay rates. It gets back to the whole issue is you're underfunded for Medicare and Medicaid. Plus, in addition, now over 50% of a hospital's bad debt is what's called insured bad debt, because the payers have changed their plan design to turn providers into debt collectors. And so as a result, the only option you have that the government has left us with is to be a hidden taxer, if you will, of employers. And it's actually good for the employers in the long run, because if they don't subsidize underfunded Medicare and Medicaid, then at the end of the day, the services won't be available. So not only does this apply to rural hospitals, it applies to all hospitals and all healthcare providers as well. Just one example, on the physician side, Medicaid pays anesthesiologists $17 per unit. They pay Medicare pays $22 a unit, which would mean that on average, an anesthesiologist working full time would make about $150,000 to $200,000 a year, which is not what they expect. And as a result, they have to get somewhere between $60 and $100 from the per unit from the private payers. And if they don't, then they also have to get a stipend from the hospital, who then has to pay for that stipend. How do they pay it? They try to raise their rates for the employer because there's nothing you can do for Medicare and Medicaid.
Right.
So you have this vicious cycle going on, all caused by Medicare and Medicaid.
Well, so going back to managed care negotiation is key. We've heard about a few, price transparency or, tools out there. Anything you've seen or anything new developing in the market that may be helpful for healthcare providers?
Well, we'll talk about some aspects of price transparency in the future, but keep in mind that price is only useful if it's for equivalent quality and equivalent outcomes and service. And one of the things that we don't have in our industry is an ability to truly measure outcomes and service. I know, living in the trenches, that certain doctors and certain hospitals do a better job. For example, STS, the Society for Thoracic Surgeons, has a very robust way of grading quality. So you can be a 3-star, a 2-star, a 1-star hospital. But when the payers negotiate, they don't give you any more credit for 3 stars than for 1 stars, even though the outcomes are definitely better. And when you look at a lot of the academics out there publishing information about price, they don't talk, the quality they use are these knucklehead standards that were developed by CMS. And so as a result, this whole issue of price is important, but it has to be accompanied with the issue of outcomes and service.
Knowing at your slides, I guess I should say, how does a commercial pricing strategy work? Next slide.
If you turn to the next slide, what you'll see is a matrix of how I look at, people say, well, you're charging 300% of Medicare or 250% or 400% of Medicare. And when I try to analyze or develop a pricing strategy for an organization, this is the kind of matrix that I use. The first thing you do is, this is a hospital with 63% Medicare and Medicaid. Medicare in this case is paying 85% of cost, Medicaid 80% of cost. And people say, well, what about 340B? 340B is just a workaround to compensate for underfunded Medicare and Medicaid. That's another story altogether. But then, because in this new environment that we have, which is new, most of or a significant percentage of the admissions are going to come from your medical group. So you have to add the cost of employing and retaining physicians. And then most health systems now, or hospitals, are part of health systems. And then there's system overhead. The idea that there's going to be economies of scale. There aren't economies of scale in a system. There are economies of expertise. So when you add that, plus the fact that because of all the Medicare Advantage programs, the rate of denials and delays and downcoding has increased dramatically, you need to add a load for that. What's the point of getting a 5% increase if that 5% increase is going to be taken away by the fact that there's going to be more denials? So it's a very simple math problem, just addition and subtraction and multiplication. And at the end of the day, this hospital, just to break even, needs 230% of cost, which represents 271% of Medicare. Now, the question is that good or bad? And the answer is neither. It is what it is. Mm-hmm. And so can most health systems, as I said, improve efficiency? Yes. Are many of them dysfunctional? Absolutely. And they need to address it. But that doesn't mean they still need to be able to generate what they need to from the employers in order to survive. And one last point about this. If the health system doesn't get 270% of Medicare, they're going to start cutting services. The first to go is inpatient mental health. The second is rehab. The next is home health. Mm-hmm. And one of the things that we've done, by the way, to address that is because in many cases, these adjacent services are not performing well, and the health system doesn't necessarily have the competency to operate these systems, is we've done joint ventures, for example, with a hospital home health agency mm-hmm. and a for-profit, so that in home health, it's all about expense and efficiency.
Right.
The hospital didn't have the tools to do it. They now have a relationship with an organization so they can still govern what goes on, but get the expertise they need to do well.
No, that's a great point. I guess moving into industry trends, buzzwords, everything like that. I know everybody talked about value-based care. Depends on how you define it. I don't know what that means, but how is, as we look today in, what is this, April 2024, how's value-based care performing?
Value-based care is a scam, at least from my standpoint. It was an interesting idea. It's a great in theory. Most health systems don't have the culture to do it. You're either fee for service or you're risk, but when you try to blend the two, it doesn't seem to work particularly well. So most people, when they think of value-based care, think of Medicare Advantage. And if you turn to the next slide, Medicare Advantage is under a lot of regulatory pressure right now and scrutiny. When you look at how these companies make their profits, the first thing is most of the for-profit Medicare Advantage plans have an affiliated PBM, or pharmacy benefit manager. And these folks are jacking up the retail prices, so the co-payments and deductibles for patients are higher. This is from a New Mexico study that said as much as 23% of prescriptions had co-pays that exceeded the cost of the drug to the PBM. The second thing is risk scores. They're aggressively inflating risk scores. Prior authorization is a disaster. It's not only hijacked the physician's ability to practice medicine, but it causes delays and denials and a huge cost to physicians and hospitals to deal with those denials. We see aggressive, unregulated, misleading marketing, which is now being addressed through regulation. The patient's premiums are low, but if they get sick, it's going to cost them a lot of money.
Right.
And they can't go to for example, if you have cancer and an NCI designated cancer institute is in your market and they're not participating in that Medicare Advantage plan, you can't go. You're out of luck. We see most significant to me is the below market payments to providers. They say they're paying Medicare rates, but after denials and delays and downcoding, it's a lot less. This is resulting in, thank goodness, providers waking up and not participating in Medicare Advantage, which creates an inadequate market for these Medicare Advantage plans, and eventually that will catch up to them. Last point is if this is value, meaning your cost per outcome is better, then why is it that we're seeing different independent organizations say that it's costing 14 to 20% more per patient to be in Medicare Advantage than it does in Medicare fee-for-service?
Well, so value-based, so that's really helpful on all of those. But like value-based care came out of this whole belief that we should provide health care instead of just sick care. What I mean, what are your thoughts there? I mean, like it had an altruistic belief, but everybody says we should be praying wellness and health and all of that. We shouldn't just be sick care facilities.
So I'm 70, and so the likelihood of me getting sick soon is really good, and I'm really thankful that we have a great sick care system. It can be better, but it's generally oriented to taking care of the sick. What we do well for hospitals and physicians, and what turns out to generate a return on investment, is interventions, mammography, colonoscopies, certain vaccines. I guess if you're kind of at least some vaccines we can all agree on. Yeah. Those kinds of things we do well. We don't do very well at reducing smoking or reducing obesity. If you look at, we've known there's 7 trillion websites that talk about diabetes and its cause and how to prevent it and all those things. Right. And yet the diabetes rates keep going up because we can't influence patient behaviors that much. Mm-hmm. The example I use is if you go out and invest in smoking cessation and you spend $5 million on smoking cessation programs and there's less lung cancer in the market, who benefits from the lower lung cancer rates in the market? It's the payer.
Right. Yeah.
So why are we doing it? That's the payer's responsibility. Exactly. If they want us to do it, pay us for our time. And if not, we can't barely afford to run our intensive care units and our EDs and those kinds of things. We've got to spend our money on sick care. And again, I have nothing against it. I think it's the right place to go.
No, agree with you. I guess one other thing, just before we move past value-based care, and MA, 100% get it, but are there any value-based care approaches or providers or anything you see that are doing positive?
Yeah, I like the PACE program. I think it's kind of a medi-medi mm-hmm. kind of managed care program, and it's designed to keep very sick people out of nursing homes right. and in their homes. And they do provide a well-rounded outpatient experience that enables that to happen. So I think PACE is a good example.
Okay, no, that's good. Well, at least we have something on that front. Well, let's move to, again, that, we talked about the Kaiser model, and we know a lot of people who've moved into the health plan, hospital health plan kind of model. So is that the idea? Kind of going back to that. Everybody, I remember, on Wall Street, I don't know, like 5 or 6 years ago, everybody was like, copy Kaiser, that's the way to go. And you watched everybody get into health plans. And so how's that working out right now?
Well, Kaiser has an interesting model, and if you're in California and been there for 60 years, you have a good chance of probably proof of concept, right. But it doesn't necessarily translate to other markets. We heard Geisinger was the answer because mm-hmm. they had their own right. health plan, yeah. and their health plans, and that organization's losing tens of millions of dollars, if not hundreds of millions of dollars, and then eventually sold to Kaiser. So when you look at the actual data, and if you look at this slide, what you see is that as far as Medicare Advantage goes, the market share for the for-profit Medicare Advantage plans has increased dramatically since 2019. At the same time, there's been no material increase by the Blues or the not-for-profits, mm-hmm. meaning that which would be either Kaiser or the payviders. Those are the not-for-profits. Yeah. And a good percentage of that gray graph is actually Kaiser. And so there's no evidence a provider getting into the Medicare Advantage business can have a material impact globally. Now, we may find pockets in certain places, but generally speaking, as you can see, their market share has not increased materially over the last 5 or so years. And if you look at the right-hand side, at the bottom, you can see that the for-profits, the top 5 for-profit MA plans, have generated profits of 6.6% going down in 2021 to 4.9. But I just want to make the point that it's going to go down even further. Humana lost $500 million in a recent quarter. At the same time, all the rest of the plans, they basically have a negative margin at this point in time for Medicare Advantage. And just a note on the commercial side, because I hear this, I've had a hospital call me up and say, we have a bunch of people saying we need to do direct contracting. Well, my first question is, how well do you do direct contracting with yourself? For example, if you're your own employer health system, do you have the most efficient health plan possible just for your own employees? And if you don't, get to work on that. The commercial insurance business is not a good business. Even the top 5 have seen about a 50% decline in their margin. And the rest of the people in the business are operating essentially at break even. So again, when you get advice, take a look at a P&L statement without heroics to make sure that this makes sense. It baffles me why people are advising others to get into the health plan business. We have a fairly close health system that we work with that just terminated their 30,000 capitated lives because they claimed they were losing, I believe it was in the range of $75 million. And one of the main reasons they did that is they said, it's not the hospital, but our doctors just couldn't operate in a culture of risk and a culture of fee-for-service. Right. We had to pick one or the other. And so that's why they get out of the business. So the evidence is fairly clear. And again, it baffles me why so many folks want to get into that business.
All right. Well, we'll switch back to physicians. And this one, obviously, we'll talk a lot about this, but this has been in the news a lot. Optum acquiring a number of physicians, all the physicians fleeing, it feels like, from private practice, which I just personally, I think it's sad. Again, the whole entrepreneurial spirit, I have many friends who are physicians, whether they're clients or not clients. And that's one of their goals when they were in school was to hang up their shingle when they get out. So, what's going on there from your perspective?
Well, what's happened, as I mentioned, is 2 things. One is that Medicare has priced their product well below, or reimbursement well below inflation. And then what the insurance companies do is shadow price just a little bit above Medicare. So if Medicare doesn't increase by 5%, then the commercial insurance companies won't increase by 5% and vice versa. So what's happened is you take that, you combine that with the fact that the infrastructure cost of running a practice for cyber, just cyber alone, but also to deal with all of the denials created by the insurance companies, has forced physicians out of private to give up their precious independence and to go work for a health system, as is the fact that they can't recruit anymore because the physician group is unwilling to pay the MGMA median rate for newbies. So what's happened is about 22% of the physicians as of January 2024 are now either working for Optum or some other insurance company or a PE firm. And about 55% of the physicians are now working for health systems. And so it's just a retreat out of private practice, out of financial necessity, and nothing else.
Well, do you believe employing physicians is a good idea? Good business to be in?
So, I just published something on my LinkedIn account about that. Another thing that just mystifies me is why these drugstore companies are getting into the physician acquisition business. I think where they used to make money is either by getting better rates or by creating some risk contracts where they would get windfalls from Medicare Advantage. Those days are all over. I mean, that's a 1990s, 2000 strategy. That's not a 2020 strategy. Right. And as a result, we're already seeing Walgreens and others basically terminate their, who have spent billions buying employed physicians, now closing offices.
Right. I think that's a slide forward. Sorry, as you're...
That's fine.
Yeah. No, but keep going. Yeah, sorry about that. Yeah.
So no, it isn't, by the way.
Sorry
So
about
there. So when you look at the physician business, especially with respect to health systems, I'll tell you a couple things because I'm intimately involved in these kinds of activities. The first and foremost is that health systems invest about $250,000 per physician practice that they operate. And people say, well, why didn't they break even like they did when they were in the community? Well, that's why they came to the health system, because they can't no longer break even and make a decent compensation. So that's one issue. So how a CVS or a Walgreens is going to, quote, break even or make money by employing primary care physicians is unknown to me. The second thing that health systems do, and one of the reasons they have to invest $249,000, is their accounting. Okay, what they do is they take the ancillaries and they put them in an imaging center as opposed to in their physician's office. And as a result, revenue for that office actually declines. We also understand from MGMA that hospital-owned practices see twice as many Medicaid patients. To do a 20-minute visit with a sick Medicaid patient, the doctor will be reimbursed $80. It's insane. And so the Medicaid patients are still going to the hospital. In fact, where they're going is to the EDs. And so 40% of the ED visits in our hospitals are still Medicaid. The next thing is that hospitals don't have a revenue cycle that necessarily works well with physician practices. Hospitals round off to the nearest thousand, physicians round off to the nearest penny. And finally, hospital-owned practices have higher overhead. Their benefits for their staff are better, their employment costs are better, and then they put on, quote, system allocations. And when you load all that stuff up, you're going to see like $250,000 a doctor. I guess one other point I'll make about that is that, again, the hospital's willing to recruit a orthopedic surgeon out of school and pay him $450,000, him or her, the first year, whereas you don't see that in private practice too often.
Right. Okay. Well, so we hear a lot jumping around to price transparency. So do you think, consumerism, that's the new trend, one of the other buzzwords besides value-based care, newer, I would say. So do you think price transparency, people knowing how much their visit's going to cost or imaging or anything like that, is that going to help reduce prices?
Right. So the first response to that has to do with what we talked about earlier, that a price without equivalent measures of quality is useless. They did a study in 2018 where they took this poor woman and sent her to 10 different MRI centers. And you hear all the time from the academics, oh, MRI is an MRI, so, it's a commodity, so we should lower if your price is too high, you need to lower it. Well, it turns out that in half the cases, the diagnosis from these MRIs for the same patient were wrong. And another great example is Mayo. Walmart has a deal with Mayo. And in the literature, they talk about that they sent cancer patients that were diagnosed and treated in the local markets to Mayo. They found that 10% of those people didn't have cancer, and I think it was 40% that had the wrong diagnosis or treatment. So what is the cost of a wrong diagnosis and treatment? So this whole idea of price transparency is just bad. And what it's going to do is, if it drives prices down, it's going to force health systems to reduce their services. And what it will do is force physicians who are in short supply to stop taking Medicare and Medicaid and just concentrate on the better paying commercially insured patients. The other thing is this chart here. What this shows is that the top 5% of the population consumes about 51% of all healthcare dollars, and they spend about $61,000 a year. The top 10% consumes 86% of the healthcare dollars. And what's even more significant is the bottom 50% don't even consume 374.
It's negligible.
It's negligible, right? And the whole issue here is that the people that are consuming 80% of our healthcare dollars, they're not going to shop. They're in the system. They're going to be listening to their doctors. Our problem is we're not developing systems of care for these people. So if you have cancer, you're going to enter a system of care, or MS, a system of care, and that's something that we need to work on.
Well, you sound bearish, Nate. I mean, I know you're providing some solutions, but you're not Mr. Optimist. But I mean, you're leaving us here, hospitals, physicians, healthcare, all these, gloomy. It sounds gloomy. So, I mean, where are we? Like, how do you want to wrap?
Well, a couple of things. First of all, yeah, they called me Neutron Nate back in the day when I was doing a lot of speeches. But if you go to the next slide, here's why I'm bullish. I mean, the first job of having a decent business, and a business means you're basically revenues are greater than expenses. That's a business.
Yeah.
We know that there will be 30,000 fewer beds, or we forecast that. SG2 has forecasted that and published that information. We expect inpatient volume to increase by 2%. The good hospitals are full. They're full every day. People are being boarded in the EDs right now, waiting for a bed. One of the reasons they're doing that is because many of the MA plans require 4 days to pre-authorize discharge to a nursing home, another story altogether. So I'm bullish about the fact that we're going to have the volume. We have to just figure out how we're going to get paid fairly for that volume. And that's going to take some time. On the other hand, I think we also, as I say, you can't fight gravity. We know that orthopedics is going outpatient. We need to be the ones that develop partnerships with orthopedic surgeons and GI physicians to do outpatient centers. And then home care is going to be a huge business in the future, and it's going to grow by 20%. So we're going to have the demand. We just have to figure out how to make money out of that demand. So my belief is there's going to be winners and losers, and what you want to be is a winner. Somebody once said success leaves clues. I mean, there are health systems that are doing well, and the issue is we need to study those systems. I've had the opportunity to spend a couple of days with HCA and others, and I will say that nobody has their act totally together, but they're pieces in all of these organizations that we can learn from in order to determine how to survive. I think my advice to people is, if you survive long enough to see tomorrow, it may bring you the answer that seems impossible today. And that's where I'm focusing on. Just work with your doctors and your clinical people, listen to them, understand what they're saying, look at the industry, don't look at the stories, look at the profit and loss statements, and figure out what's working and what isn't. And if you do those things, the chances are reasonably good you'll be successful.
Well, Nate, that's really great. I mean, one of the things you talked about, and people who know you or follow you on LinkedIn, they know that you have the vantage point, or you can perch in a number of different organizations you speak with. And again, that's what I think, one of the major things you offer is, the context of time and seeing things over time and perspective and being grounded, whether it's, like you said, being in the trenches or going back to the basics of the P&L, but also, the insights you have from not just the time that you traveled across the U.S. speaking, but even today, as you are like the right-hand man, woman, whatever you want to call it, to a lot of executives in terms of seeing what's going on there and applying what you've learned in this market or this system or this organization. And I think that's a huge value add. And it's something that people should, look to use your expertise on. Anything else you wanted to kind of wrap up and close? It's been a great discussion.
Yeah, I think that ultimately, this is all about getting the right advice. Nobody has all the answers. There are academics and policy makers out there who have no clue what it's like to operate in a health system, who are giving advice to employers and to others about, and the government officials about what to do in healthcare. And, I'm not very smart. I tried to get into medical school. I couldn't make it. But I've been relatively successful. And what's made me successful is to get in the business, understand what's going on, and most importantly, talk to the doctors and nurses and other clinical personnel who are on the front lines. If we spend our time listening to them, we'll be successful. And if we don't, well, listening to them and also solving that equation. Those are the two things. And if you do those things, you'll be just fine.
Well, on that note, that was great. Thank you, Nate. Appreciate you kicking off our first podcast, and It's been great having you on, and look forward to wherever we go from here.
Yeah, I look forward to seeing you sometime, probably in the office in the next hour or so.